Welcome to this explainer. I am absolutely thrilled to have you here today. We're going to jump right into a really dynamic, comprehensive overview of two of the most critical vascular emergencies in human anatomy. We're talking about the Vena Cava syndromes. I love organizing complex medical concepts, and today we're going to break down the body's ultimate venous highways to truly understand what goes wrong when that traffic comes to a sudden, catastrophic halt. So let's think about this for a second. Imagine the superior and inferior vena cava not just as blood vessels, but as the body's primary transit corridors. They are massive rivers responsible for returning almost all of our oxygen-depleted blood back to the heart. The superior vena cava is our northern highway, handling the upper body. And the inferior vena cava, that's the southern highway, draining everything below the diaphragm. But what happens when these major routes face a massive blockage? Well, the resulting traffic jam isn't just a minor inconvenience. It literally triggers a cascade of rapid, life-threatening hemodynamic failures. To really unpack this, we'll run through this like a set of clinical rounds. We'll cover the anatomy of the great veins, mechanisms and causes, the alarming clinical picture, classification systems, precision diagnostics, and finally, endovascular and surgical treatment. All right, part one, anatomy of the great veins. There's a sheer, wild contrast in their physical environments. The superior vena cava, or SVC, handles about a third of the body's blood volume. It's got incredibly thin walls and operates under very low pressure, sitting right in the crowded, rigid space of the anterior mediastinum. That makes it super vulnerable to being pinched closed by anything expanding nearby, like a tumor or an enlarged lymph node. On the flip side, the inferior vena cava, the IVC, is just an absolute powerhouse, collecting 2/3 of the body's blood. It sits deep in the retroperitoneal space and has an incredibly complex 3-part embryonic origin. Because it actually forms from multiple embryonic segments fusing together, it's prone to congenital anomalies like duplications, which can create turbulent blood flow much later in life. And this brings us to the body's brilliant, built-in backup plan, collateral circulation. When a main highway is blocked, the body desperately tries to build a detour. The absolute MVP here is the azygous vein system. Now, if a blockage forms slowly, say from a slow-growing tumor, these collateral veins actually have time to expand and reroute the blood, keeping the patient relatively stable. But if the occlusion is rapid, those detours simply can't handle the massive volume, and the pressure builds up to totally catastrophic levels. Let's move on to Section 2, Mechanisms and Causes of Occlusion. The historical evolution of SVC syndrome is genuinely fascinating. Back in 1757, William Hunter first described it in a patient with a syphilitic aortic aneurysm. And right up until the mid-20th century, infectious diseases like tuberculosis and syphilis were the main culprits. But modern medicine has completely flipped the script. Today, thanks to antibiotics, infections are pretty rare causes. Instead, an overwhelming 60 to 90% of cases are now driven by oncology, specifically tumors compressing the vein, and iatrogenic causes. By that, I mean medical interventions like central venous catheters or pacemakers that accidentally damage the vein wall and provoke clots. If we compare the two syndromes directly, it's pretty revealing. For the SVC, malignant causes completely dominate the landscape, specifically small cell and non-small cell lung cancers, which make up to 80% of malignant occlusions. The tumors literally just crush the thin-walled vein. But for the IVC, we see a totally different profile. Malignancies down there usually involve tumors actively growing into the vein itself, like renal cell or hepatocellular carcinomas. Crucially, though, the IVC is heavily plagued by benign and thrombotic issues. We're talking deep vein thrombosis, genetic hypercoagulation disorders like factor V Leiden, and even temporary compression during late pregnancy. Section 3. The alarming clinical picture. The clinical presentation here paints a vivid, really terrifying picture. When the northern highway, the SVC, is blocked, fluid violently backs up into the upper body. Patients develop what's called a Stokes collar, which is this profound swelling and bluish discoloration of the face and neck, along with bulging chest veins. Even more alarming, that pressure backs up right into the brain, causing cerebral venous hypertension, severe headaches, and altered consciousness. Conversely, when the southern highway blocks, the lower half of the body takes the hit. We see massive, heavy bilateral leg swelling, painful venous claudication when trying to walk, and prominent vertical varicose veins literally marching up the abdomen as the blood desperately tries to find a detour. If that blockage reaches the liver or kidneys, you're looking at acute organ failure. So an absolutely critical point is how differently this presents across ages. In adults, an SVC obstruction is undeniably serious, But because adults have rigid windpipes and those collaterals form gradually, the swelling is often tolerable for a little while. But in pediatric patients, it is an absolute immediate nightmare. Children have a soft, highly pliable trachea. The swelling from all that trapped venous blood quickly crushes their airway. Pediatric SVC syndrome is an extreme, highly lethal emergency that requires immediate, life-saving intervention just to secure their breathing. Moving right along to Section 4, Classification Systems. For SVC syndrome, clinicians rely on the Yale grading system to bring order to the chaos. It's a straight-up roadmap from 0 to 5. Grades 0 and 1 represent mild swelling, so doctors can afford to take a conservative approach. But the exact moment a patient hits grades 3 and 4, showing signs of severe brain swelling or stridor, which is that terrifying high-pitched wheezing indicating the airway is closing, the priority shifts immediately. It becomes all about urgent life-saving stenting to prop that vein open. Grade 5, tragically, is fatal. Contrast that with the IVC, where blockages often lead to a chronic, devastating downward spiral classified by the CEP system. This system tracks the slow-motion destruction of the lower body's venous return. It starts off mildly enough at classes 1 and 2, with spider and varicose veins. But if that pressure isn't relieved, it aggressively progresses to classes 4 through 6, causing irreversible tissue damage, skin hyperpigmentation, and eventually massive, active trophic ulcers on the legs that simply refuse to heal. Which brings us to Section 5, Precision Diagnostics. Diagnosing these syndromes is like walking up a very precise staircase. Step 1 is always clinical suspicion, taking a thorough medical history and using tools like the Wells score to gauge the probability of a blood clot. Step 2 is where we get into laboratory analysis. Doctors are checking for D-dimer to hunt for acute clots or tumor biomarkers like LDH to hint at aggressive lymphomas or lung cancers. But Step 3, that's where the magic happens. Multi-slice CT angiography with contrast. This is the absolute gold standard. It lights up the entire vascular system, showing clinicians exactly where the blockage is, how severe it is, and exactly what those collateral detour routes look like. Once that blockage is pinpointed, doctors need to know exactly what they're up against. For the SVC, if there's a tumor, they use a technique called EBUS-TBNA. It's essentially an ultrasound-guided needle pushed safely through the airway. This provides a gold standard biopsy without the massive bleeding risk of cutting into highly pressurized swollen tissues. For the IVC, especially when they're preparing to open it up, surgeons use intravascular ultrasound, or IVUS. This is literally a tiny ultrasound camera threaded inside the vein itself, giving them perfect internal measurements so they know exactly what size stent they need to use. And finally, Section 6, Endovascular and Surgical Treatment. Medical management sets the absolute foundation here. We use dexamethasone, a powerful steroid, to rapidly shrink the inflammatory swelling around tumors in the SVC. Loop diuretics like furosemide drop the overall blood volume to give the patient some temporary relief from that severe facial swelling. But for the massive thrombotic clots, especially down in the IVC, aggressive systemic anticoagulation is just non-negotiable. And if a clot is fresh and acute, doctors can deploy catheter-directed thrombolysis, feeding a tube directly into the clot to blast it with dissolving medication. But here is the true game changer, 95 to 100%. Let that sink in. That is the technical success rate of modern endovascular stenting. By threading a collapsed metal tube into the blocked vein and expanding it, doctors can instantly restore blood flow. The clinical relief is genuinely astonishing. Patients who were literally suffocating from head swelling see their symptoms disappear in just 24 to 72 hours. It is an absolute triumph of modern minimally invasive surgery. Now, the hardware required to fix these two highways is vastly different. For the superior Vena Cava, doctors use 14 to 20 millimeter self-expanding metal stents, often placed under nothing more than local anesthesia. But the inferior Vena Cava, that's a totally different beast. It has to withstand heavy abdominal pressures and massive blood volumes. Stenting the IVC requires gigantic 20 to 24 millimeter nitinol stents, engineered with ultra-high radial force, just to keep the vessel from collapsing right back in on itself. Of course, stenting isn't a magic bullet for every single scenario. When stents fail, or when dealing with complex benign tumors that can actually be surgically removed, doctors hold open bypass surgeries in reserve. A brilliant example of this is Ray Chu's spiral saphenous vein technique. Get this. Surgeons actually take a patient's own leg vein, split it open, and spiral it around a template to create a brand new, large diameter, custom biological pipe to bypass the blockage. Synthetic grafts are used too, but these organic bypasses are just an incredible display of surgical ingenuity. Which brings us to our final thought. We are living in an era of rapid, mind-blowing medical evolution. With the continuous advancement of targeted cancer therapies shrinking tumors non-invasively and the development of next-generation stents coated with advanced anti-clotting medications, we really have to ask, will these incredibly complex, open vascular bypass surgeries soon become a relic of the past? It's a thrilling question for the future of vascular medicine. Thank you so much for joining me on this explainer. I really hope this deep dive gave you a clear, powerful understanding of these vital anatomical pathways. Keep learning, and I'll see you next time.